Well, good afternoon, everyone. Thank you so much for joining us today. We are thrilled to see many of you in the room, and I know there are hundreds more joining online. This is our first hybrid interconnected event session, and we are absolutely thrilled to see everybody today. This is a really important discussion about mental health services and suicide prevention in the state of Minnesota. And we're really glad that you joined us. My name is Jake Loesch, and I'm the executive director of the Citizens League. We are a nonpartisan, nonprofit organization that really focuses on empowering people to engage in civic life and the policymaking process. For more than 70 years, Citizens League has been working to bridge divides and create strong public policy outcomes. And I think part of that work is convening conversations just like we're going to have today. We've been really proud to partner with the Center for Rural Policy Development on this series as well. Marnie's here, others are online. The Center is a policy research organization providing unbiased information and evaluation of issues from a rural perspective. And I think Interconnected was really envisioned as a series to bring together rural and urban communities to better understand each other's needs and challenges, and perhaps more importantly, where those commonalities and shared opportunities lie. Like I said, I'm thrilled to welcome you all for our first hybrid Interconnected, where we have some people in the room joining us in person and hundreds more online. And especially I want to thank our panelists today, all of whom bring deep expertise in mental health issues and policy around the state of Minnesota, and I think are really going to help us understand both the challenges and the solutions that we have to face. So with that, I am going to exit the screen and hand it over to Kate Raditz, our moderator with Park Street PR, and the panelists. Thank you all very much. And to those of you online, thank you for being with us. Looking forward to the conversation.
Hello. And we're actually going to start off with Marnie doing a presentation, a little bit condensed presentation of the new report out from the Center for Rural Policy and Development. But I think I need to get closer.
Sure.
But welcome, everyone.
Okay, and I'm just going to share my screen here. And there we go. Can everyone see that okay? Okay, great. Yeah, so this is a report that we just released last week. Myself and sitting next to me, Dr. Tracie Rutherford self. We worked on this for the better part of a year. And the suicide epidemic in rural Minnesota. And so first of all, we'll just talk about a little of where we're at. You can see that suicides have been on the rise since about 2000. You can see the line there marking that. And a lot of this has to do with diseases and deaths of despair. And what is that? That was a term that was coined in 2015 by a couple of researchers who noticed an acute rise in the number of suicides, a number of deaths by drug poisoning or overdose, and alcohol-related diseases. And these have been rising steadily since 1999, as you can see from this chart, particularly drugs and alcohol in the last few years. Minnesota has a suicide prevention plan that the Department of Health and the State Suicide Prevention Task Force has put together. And they identified several groups as populations of particular concern. And that's the youth ages 10 to 24, Native Americans, Black and African Americans, middle-aged men, LGBTQ plus community, veterans, and people with disabilities. And you can see in the chart on the right, this is broken out by male and female and by age group. And so you can see particularly with the males, those higher rates in the 20 to 24 and 25 to 29 age groups, and then also in the middle-aged age groups there. And so the point of our report was to see what is going on with suicide in rural Minnesota. We knew that the suicide rate is higher in rural areas, and that's due to several specific reasons that we'll go into more so during the panel discussion. But this is the state broken out by regions, and you can see since 2018, the higher rates have been in Northeast Minnesota and in Northwest Minnesota. The 7-county metros actually has the lowest rates in the state. And then this is looking at rates since 1999 to 2021 by, I guess you call it population density. And the entirely rural counties are that green line on the top. That's the trend line showing that the trend of their rates is going up faster than the other areas. And you can see that the less dense the population, the faster the suicide rate is trending. So why are suicide rates higher in rural areas? There are fewer mental health care providers. That's a big issue. Isolation, financial barriers to getting help, more jobs and industries in rural areas that involve physical and manual labor, hard labor that can involve chronic pain, insufficient outreach and education about resources, stigma and privacy concerns, and then also more access to firearms. One particular group that we know needs to be discussed is Native Americans. Their suicide rate has been higher than the general population for many years. And the rate in Minnesota for Native Americans is higher than the average rate for Native Americans in the US in general too. So that was concerning to find. And then farmers too. Farmers were a big topic of discussion before the pandemic started, and it's still an issue. We have a farm stress network counselor on the panel today. Farmers struggle with a unique set of issues, including volatile income, fear of losing the farm, and stigma around mental health. And then access to firearms. In rural areas, there are simply more guns. More people own guns. And so you can see in the chart on the right that in the entirely rural area, there's a higher percentage of people using firearms for suicide. And you can see at the state level, it's about half. It's a little under half use firearms, but it's higher in rural areas. And when you take firearms out of the mix, you can see that the suicide rate drops considerably. And we'll probably talk about this more on the panel, but it has to do with the fact that taking your own life is an act of an impulse. And if you have a gun at hand, it's easier to make that happen than if you're using a bottle of pills or something like that. But it is a far bigger discussion that needs to be talked about, how to handle it and what message to go with. And so what do we do? 988 is a big tool. It's a strong tool. We've had a suicide prevention lifeline in place for many years, but it was changed to 988 2 years ago to make it easier to remember. And so comparing the suicide rate by region and then the call usage, the 988 usage by region, it's not causation, but there's maybe a bit of correlation going on there where the metro counties have the lowest rate of suicide and the highest usage of 988, and just the opposite for Northeast. But 988 hasn't been widely promoted yet. They're just starting to do that now because they didn't have the capacity to do that before. And so now I know the Department of Health is really starting to roll out PSAs about 988. And so that is an important tool that people need to know about. It's not just for suicide, it's for about any kind of mental health crisis. And so moving forward, from this paper, Dr. Self interviewed several professionals in the field and pretty much settled on 4 big concepts from talking with them about what to do going forward or what to be aware of. And one important theme is anchor members, anchor members of the community. There's formal help and informal help. And these friends and family members are, probably in the best position due to the lack of mental health professionals and providers, due to the fact that people will turn to a family member or a friend first when they're feeling in a crisis to talk to someone. They're in the best position to ask the person, how are you doing? Is there something we can do to help? And talk like that. And therefore, there's the idea about helping to train members of the community for how they can help with mental health. Integrated behavioral health, having a counselor at the same facility as the doctor. People feel much more comfortable going to their family doctor than they do to a mental health professional who they maybe don't know. Would be the first time they're meeting this person. In the report, one of the interviewees talked about doing a warm handoff. The doctor detected there was an issue. He called in the counselor and she talked to this person, and it worked well because no one had to see her coming in there. And the person was there and she was able to just talk to them. Rural cultural competence is important for providers, new people who may be coming into rural areas. We talk about this quite a bit in the report. Understanding rural culture is important. There's a high value on independence and self-reliance. There's an issue of isolation, lack of trust of those outside their social network. Tracie has great stories about how she has integrated herself into her rural community in Iowa that she worked in for many years. The lack of anonymity and the stigma around mental health is something that providers need to understand when they're coming into a rural community. It may be a little different from working in an urban or suburban area. And then just talking about suicide. There's concern that if we talk about suicide, it'll lead to suicide contagion. And suicide contagion is a real thing, but talking about suicide in the right way can actually relieve that pressure on the person. It can help them share what's troubling them and normalize the discussion. And so that's what we have for the presentation. So Kate, would you like to take it away with the panel?
Thanks so much, Marnie. And thanks everyone for joining us in person today, everyone online joining us. I'm Kate Raditz. As you just heard this report from the Center for Rural Policy and Development, this is a heavy topic. This is a serious topic, but an important one to dive deeper into, which is why I'm guessing so many of you are here and why so many are joining online, especially from greater Minnesota, to try to get to the root of this, as the report did, and hopefully explore some solutions as well. So I'm Kate Raditz. I'm the Director of Public Relations and Communications at Park Street PR. We're a full-service PR firm, but we work with the Center for Rural Policy and Development, and we have so enjoyed this partnership with Citizens League and doing this interconnected series, especially our first hybrid today. So this is being recorded. Typically, I have a computer in front of me as well when I've done this strictly online, so I can monitor the questions, but we have Kelly in the back over here with CRPD. He is going to be monitoring that. So I will take pauses in my questions, for the panel, and see if any of the people online have questions. If any of you in person have questions, I'll just stop and ask if you have any. Feel free to ask any of our panelists, and I'll try to get to all of those. This will be posted to YouTube, to the Center for Rural Policy and Development's YouTube page after we wrap here. Maybe not immediately, but it will go up there, so keep an eye out. And I think that's kind of the housekeeping rules. With that, I'm going to introduce our panelists, and then we will just jump right into questions. So you've already met Marnie Werner. She is the Vice President of Research and Operations for the Center for Rural Policy and Development. We have Dr. Tracie Rutherford Self from the Department of Counseling and Student Personnel at Minnesota State University, Mankato. And David Goehl-Manolis, Suicide Prevention Coordinator for NAMI Minnesota, the National Alliance on Mental Illness Minnesota. And joining us online, we have Monica McConkey, a licensed marriage and family therapist and rural mental health specialist. Thanks everyone for joining us. And I'm just going to jump right in, and these really go off of that report that Marnie was talking about, this really great report from the center. So first, for the panelists, I would love for this to be a conversation, but I'll try to jump around a little bit, give each of you a little time to think about each question. If you don't think you're the best person to answer the question, feel free to whoever feels best to go ahead and jump in. But Marnie, I'll start with you. Looking at this report, of course, it talks about, death rates, which were trending down until about 2009. Now they've been climbing again. I mean, that is significant. How concerning is that? And I'll ask all of you this, how concerning is that to see this trend that was actually going down now going up again?
Well, just looking at the trend line is concerning, but then when I talk with people who have been affected by this directly, you really start to feel the tragic whatever the word for tragicness is, the tragedy of this all. The number of families that this is being affected. I think back when I was a kid, you heard maybe once in a while about someone taking their own life. But now it's like almost every day I hear another story from just in my social circle about, someone's son or someone's niece, has overdosed or used a gun or something like that. And so it really has gotten to an epidemic stage, it seems. And just, being just a policy researcher and not even a mental health researcher, I can see that it's a crisis. There really isn't another word for it.
It is a crisis, Dr. Rutherford self, looking at the big picture, is there any one answer for why is this happening? I'm guessing not, but what would you say?
No, I don't believe there is one answer. I think there's multiple facets at play here. But I think if we could look at one thing in particular, the thing I would come back to consistently is the fact that talking about suicide is still incredibly taboo. So many people simply don't have conversations when they're starting to have thoughts of suicide. They will keep that to themselves. They're afraid of what happens. As a mental health professional for almost 2 decades, it's interesting because I'll bring clients in and that's one of my first questions and I can see the hesitation. And the hesitation is always like, should I honestly tell her that I'm having thoughts of suicide? What happens if I tell her I'm having thoughts of suicide? I worked with a client the other day who was having thoughts and we talked about hospitalization and her response is, I have a special needs child. I can't possibly go to the hospital right now because who's going to take care of that child? So sometimes the fear of what's going to happen, because it is such a taboo topic still, keeps us from having conversations about the fact that suicide and suicidal ideation is incredibly common. I have a philosophy that I think probably everybody on the planet at some point in their life has had a thought of suicide. For some people that happens more pervasively and for other people it doesn't, but we still don't have those conversations on an ongoing basis. And I think that is one of the key pieces we have to start doing in order to really address the epidemic.
Can I follow up with that? Do you think people don't know how to talk about it?
Yeah.
Can you speak to that?
Absolutely. And frankly, even professionals sometimes don't know how to talk about it. And that's an even bigger concern. So in my position, I'm teaching people how to be counselors. And when we look at this historically, it really was only about 10 years ago, we started teaching professionals how to have conversations around suicide. So if we have professionals who aren't sure how to ask the questions, and again, that isn't true across the board, nothing is. But when we have professionals who were never taught how to have those conversations and they don't ask the right questions. And the main reason people don't ask questions, whether it's professionals or if it's lay people in the field or if it's other individuals, is they are afraid of what happens if someone says yes. What do I do? What's my response? How am I supposed to address this topic in this situation? Because I don't want to do it wrong. So instead of doing it wrong, I'm just not going to ask any of the questions.
David, you are a suicide prevention coordinator. What have you noticed? We talk about the death rates trending down until 2009, but in looking this report, what was your takeaway from that?
I think that the death rates definitely are concerning. But I want to just expand that the suicidal behaviors are very common. When we talk about the statistics, that the number of people who have attempted suicide and survived is, I think the ratio is around 25 people who have attempted and survived to one person that has died. And so you can imagine the millions of people that have attempted and survived. But then there's even another level to it. And those are people that have had such serious thoughts of suicide, but haven't attempted. And then I think that the last statistics I saw from the Suicide Prevention and Resource Center were that there was over 12 million people in 2021 that had serious thoughts of suicide. And so there are millions of people who, as you were saying, that it's very common to have thoughts of suicide as just a way of feeling overwhelmed by the life problems that somebody might be encountering, and that they can't think of solutions, and that builds in their mind. And I think what you were saying is right on, that building our comfort with even saying the word suicide, talking about mental health, talking about the impact that stress has on just on people, on communities, can open the door to releasing some of that internal pressure. And so that's, you know, I see the numbers trending upwards. I agree that that's concerning. It's equally concerning about how common the suicidal behaviors that don't lead to a death.
Monica, can you weigh in just in, you know, in your work, why same question of what have you noticed as to why this has become such a crisis?
Oh gosh, I would agree that there are many reasons, contributing factors for why, you know, in rural areas, the report really hit the nail on the head that there's a lack of services, lack of resources, increased isolation, stigma is still alive and well in our rural farm communities. So lots of reasons why, you know, this sense of hopelessness that is really pervasive among so many people. And another thing to add is for every death by suicide, there are a number of people, survivors, that are impacted. And we know that their risk for a suicide attempt or death by suicide also increases when they have lost a friend or a loved one to suicide. So that compounds the issues, and the ripple effect is even larger as the death numbers go up.
I think we have. Sorry, Monica, we're just trying to see if we can get some captions up there for people here in person. So it's a little bit louder.
Okay.
We can keep, oh, I think it should be up. We should be good now. Thank you, Monica. Marnie, you know, what role did the pandemic play in this data?
Well, that's probably a better question for Tracie and
Yeah.
David, but we did see that there was actually a small drop in suicides in 2020. But then it shot right back up again in 2021. But the deaths from drug and alcohol abuse really went up during the pandemic.
Yeah, so we weren't expecting to see that data that originally came out. So when we were going through the pandemic, the anticipation was we would see a pretty dramatic increase in suicidal deaths. And we didn't actually see that, except we did. So what happened was when we didn't see what we expected, they started pulling that data apart to kind of see based on different populations. And what happened was that rate actually dropped among white middle-class men, but actually increased for marginalized populations, and increased like for those with low SES who might not have had the same access to resources and who were more stressed by the pandemic. It increased particularly for Black men, and that increase actually started to spike around incidents like George Floyd. So what we saw was a drop, but that drop really is a bit deceptive because it was really only a drop for people with the greatest access to resources.
Sure. David, you know, the rate of suicides are about, Marnie talked about in this report, and I'm sure you're aware, the rate of suicides are about 4 times higher for men.
Right.
When compared to women. What do we know about why our men in particular seem to be struggling more than women?
I think when you look at the statistics about the means that somebody uses in their suicide attempt, men are much more likely to use firearms in their attempt. The death rate from using a firearm in a suicide attempt is between 90 and 95% of people who choose to use a firearm in their attempt. About 90 to 95% of those people will die in their attempt. No other means is close to that level of lethality. And so women actually attempt suicide almost 3 to 4 times more frequently than men do. The means that they most frequently use, though, are means that have a much higher survival rate. And so they tend to survive their attempts way more frequently than men. And that's the primary driver behind the higher death rates among men in their suicide attempts.
The report noted that the suicide rates are higher in rural areas compared to, the metro. But is it fair to say not a lot of people know about this, that they realize how much of a crisis this is? Since I think we have our captions working now, Monica, maybe I'll ask you that question. I'll start with you.
Well, I think we tend to, in any rural state, there's a tendency to be more metro focused. Wherever the mass of the population is, a lot of the attention goes to that geographic area. And I think the same thing happens in Minnesota. And so, yeah, I agree that it is fair to say that not a lot of people know about this crisis in our rural areas. Rural areas are fairly isolated. It's not often talked about, except within the community, because they know it's not published, in obituaries often. So yes, I think it is news to people to hear that suicide rates are higher in rural than in urban.
Marnie, when you were doing this report, what was some of the feedback you got, in talking to people and talking to people in rural Minnesota, that there was a lot of interest in this and wanting more focus and attention on this?
Oh, there absolutely was. People are just, I talked to people anecdotally for this report. Tracie did all the actual interviews for the research part of it, but just in my telling people we were working on this, there was just almost desperation for information, on what to do. So.
Can you weigh in as well?
Yeah, absolutely. I think there's definitely a lot of interest. I want to go back and address a couple of things really quickly, though. So suicide in rural areas across the board, across the country, are happening at almost 2 times the rate for rural populations than it is for more urban and suburban populations. And that's a really key number to have. And the other thing that's super interesting about this is individuals who die from suicide, because we don't always track the data for individuals who may have attempted or have ideation, but individuals who die by suicide from rural communities almost never have a mental health diagnosis prior to their death. And so what that's telling us is they're not reaching out. That's one of the things we know, is they're not seeing a mental health professional. And again, I go back to Monica really speaks to this quite well, talking about that isolation piece, talking about the fact that we're not having these conversations. And yet, I think a lot of people are really interested in continuing to have those conversations and wanting to know more and being able to talk about it more. But I'd go back to some of what we were talking about before, and that is the fear of, how do I have these conversations? What do I do? And if there is a lack of availability of providers in that area, then who do I refer to? We talked about this a little bit in the report, but even when we have someone who goes in and they have to be hospitalized for suicidal ideation or behaviors, where are they even going? So they can go anywhere across the state, and in some cases across state lines. And for people in a rural community who may traditionally have a lower socioeconomic status, particularly when I'm looking at littles, I work a lot with littles, and if a little's being transported 4 hours away because that's the only place we can find a bed for them, then how does the family deal with that? How does the family even see that child? How do they go to pick them up? I mean, all those things create this cascade effect of, how do we deal with this issue in a rural community when there are so many factors at play that may be, in fact, creating some of this issue for families and not wanting to come forward?
The access to mental health services is very different in greater Minnesota than compared to the metro.
Oh, absolutely. Because again, you can't access the same level of services. And so we talked about this a little bit in the report and some of the interviews I've done, and my own experiences. I have particularly a child. It's really hard when you've got someone under the age of 18 who goes in. They usually see someone through telehealth to do the assessment in the ER, and then they can linger in an ER for days, weeks, actually, in some cases, while we're trying to find a bed. And there are families who get to a point, I've had my own clients where they look at it and say, we think the suicidal crisis is past. They've never gone past the ER, and then they go home. And if that's happening, then they're not getting the care they need. So if we're not getting the care we need because we go home and we don't have the same access to care, then we're really back in the same situation without really remedying it at all.
Marnie, are the financial situations or the financial barriers different when you look at greater Minnesota?
Well, yeah, like Tracy said, they're, on average, there is a lower in median income in rural areas. In some of the counties, it can be quite a bit lower than in the metro area. But also there are more people on Medicare, Medicaid in rural areas, and that affects the ability to pay for services. And that, which then affects the ability of a provider to even practice in rural areas, and be able to get paid. But then, because there's just a greater proportion of small businesses in rural areas, there are more employees who are less likely to have health insurance through their employer. Or it may be a scaled down health insurance that doesn't cover mental health services or something like that. And so that is probably the bigger issue, even, is just that access to health insurance to be able to afford services.
I will pause and see if anyone, Kelly, if there have been any questions from online. Did you have a question for the panel?
Yeah, we have a few.
Okay, go for
Start
it.
with the one, there's some questions around deaths of despair and how that relates to suicide. So as you guys are talking about suicide, how do things like overdoses and things like that play a role?
Anyone want to jump in on that? Dave?
Well, they're very closely related. That the high stress situations and how people respond to high stress situations. Oftentimes, the substance use disorders stem from that same almost self-medicating to stress and anxiety, and maybe even self-medicating for a mental illness that may be undiagnosed. And the other factor to think about is that when you look at the number of suicide deaths, those deaths are collected by epidemiologists by identifying the cause of death on death certificates. And that's the medical examiners need to know for sure that it was suicide. And there's an awful lot of deaths where it's uncertain. And so there could be something that's labeled as an accidental overdose that may have been a suicide. That there is also a very close correlation between alcohol abuse and suicidal behaviors. Statistics that I remember, and you may know the statistics more off the top of your head, but something over 65% of people who attempt suicide at the time of their attempt had above the legal limit of alcohol in their system. So they call them deaths of despair because they're related, but the suicide, substance use disorders, doses, all kind of stem from the same types of pressures, and there's a great deal of overlap.
Any other questions, Kelly?
Yeah, and I'm a bit muffled, so you'll have to repeat my question.
Sure.
Can somebody explain transportation is an issue for access to mental health? How big of a role does that play?
The question was asking, how does access to transportation play in getting mental health services?
You have thoughts on that?
Oh, I have lots of thoughts. So the truth is, accessibility is one of the biggest issues in rural communities in general. And when we talk accessibility, part of that is transportation. So again, if we're looking at a population that may have a lower SES, and again, this is on a continuum, so there isn't necessarily one response that always fits all. But if you can't get to your practitioner's office, then it's really hard to actually access the care that you need. And so my practice was in a town of about 2,500 people, and I saw about half my clients were Medicaid. So typically low SES, and even when they could get access to transportation, a lot of times what would happen is that transportation would break down. So I would get phone calls 30 minutes before saying, hey, I can't make it in. And a lot of times what we thought is, okay, now that we've gone through COVID and we're using telehealth, that's how we're going to fix the transportation issue. But I would tell you in rural communities, there are two issues with that. The first is, for a lot of people, they need a warm body in the room. And we saw this with our interviewees as well, is that if I'm going to sit here and tell you my deepest, darkest secrets, it's so much easier when you and I have this face-to-face connection to do so. And then I think we also have to realistically look at rural communities and look at broadband access. The truth is, it is not the same in rural communities. So while telehealth can certainly be a tool in the toolkit, It is not going to fix all the transportation issues that exist. And I know that there are services where you can access transportation in rural communities, busing systems. It's really hard for some of my clients with that low sort of access to resources and frankly, lower self-efficacy around those things to then take that step to get access to those resources. And the truth is, if you're already depressed, it's really hard to make a phone call and schedule a bus to come pick you up, where that bus might be picking you and 20 of your closest friends up, and you're making multiple trips around and you're waiting to have other people picked up and you're already depressed. So the transportation is a really big issue when we look at that. So we also know there are still people in rural communities who are traveling. I think one of our interviewees said up to 2 hours to see her. So some people are making that. And the other thing is we also know there are people who are still going into suburban and urban communities from rural areas in order to access that care. But we're not going to get too much into it yet, but that idea of rural competence really comes into play. So if I'm going into a suburban or urban community, but you don't understand the needs of the rural culture. So for example, most of my clients, we talk about small businesses, need evening appointments. And if you stop seeing people at 5, 6 o'clock and you don't have a 7, 8 o'clock appointment available, they can't leave that small business or that job that may not be allowing them to go outside of their community to then access that care.
If I want to jump in, there was
Yeah.
just one other factor that for farmers, farming is a time-intensive job. And oftentimes from sun up to sundown, there are tasks that need to be done. And so for a farmer to identify, I need some therapy, but the closest therapist is an hour and a half away. That's an hour and a half drive. It's an hour appointment. It's an hour and a half back. And that's money. Time is money on the farm. And that's another piece of the transportation problem that we need to consider, especially among farmers.
Any other, or I'll ask if anyone in person as well has, yeah, right here.
So I have a question. Well, it's two parts to it. I know that access, especially to culturally competent care, is non-existent in some places in greater Minnesota. So what are you doing to diversify the workforce? And two, what's also being done for the people that are currently exercising this field to get the training that they need to be able to provide culturally sensitive help, and also having that cultural awareness for certain communities, and also to gain that trust from those communities, because people of color are often at a higher rate of being what's the word where you call someone because mandated reporting. And so there's that fear also that if they come to you, that then now they're gonna have their children taken away, or they're gonna be mislabeled or misdiagnosed, or even if you are someone from Mexico and you're talking for us, you know, Day of the Dead is something that is very common, but then we get told that we are suicidal when we were just talking about our cultural experience. So what is being addressed to address those disparities? And
So I can repeat the question just so everyone can hear us, and correct me if I get this wrong. I'm taking notes, but the person asking the question noted that people of color can be nervous to reach out for help. And so there was a two-part question. One, of what is being done to diversify the workforce, and two, what training is being done to provide that more culturally sensitive help when addressing that situation. Does anyone want to take that on?
Well, I'll just jump in quick and say that that's part 2 of our research. So this study is like part 1, which is kind of an overview. We actually have another researcher now who is in the middle of a project working specifically on communities of color in rural Minnesota and finding out what their needs are and getting a better understanding of that. And so that'll be coming out sometime this summer. But turn it over to you guys.
Okay, so I want to first start by saying, frankly, not enough. I mean, I think we have to be really honest about this. And there's so many pieces to your question, and I really appreciate you bringing it up. So I'm going to talk about it from a suicidal perspective, then I'm going to come and step back and talk about it from a training perspective. So first of all, when we look at suicide assessment, it is only normed on white middle-class populations. So like I've been presenting about what does it look like? What are warning signs for marginalized people? Because it does not look the same. And we have gone with this model forever of these are the same people, and it's not. We have to have that cultural competence to understand that what might be a protective factor for one group may not look the same as a protective factor for another group. So part of this is really, it's only been within the last 7 to 8 years that we've started seeing grants coming out to study suicidality in diverse populations. So I think we're doing a little bit better, but the truth is, I'm going to go back to my original statement and say it's still not enough. As an individual who trains mental health professionals, part of our training requires that you have courses and multiple courses to better understand cultural competence. And it's an imperfect system. I mean, I just want to be clear that I think the system is imperfect. And yet for my students, I have multiple students who are out at sites at internships. So we're talking about suicide. We're talking about what it looks like from a diverse population standpoint, recognizing, frankly, we are kind of building the ship as we're trying to row it down the stream because we still don't have enough data for that. But to also recognize, I had a client from a diverse community who was talking about like seeing different types of spirits. And we had to really kind of go back in and talk about, is this a mental health situation? Or is this frankly part of your culture, and having those conversations? I've also, as a clinician, had multiple times where I had a client, usually a kiddo, who likely needed to go to the hospital, but parents were very concerned because they may have been undocumented. And so in my case, I had a really great relationship with a local center that worked with that particular population so we could find some workarounds around that, because it's a reasonable fear, right? If you're going to do this or you're going to come in and take my kids. And frankly, I think most populations have that fear when it comes to any type of mandated reporting. So we're working on doing a better job of increasing my students as they're going out into the field, their cultural competence, not just around suicide, but in general. And then I think the other thing is, and this kind of speaks back to your first point, we need more diverse providers. We don't have enough diverse providers. In our program, the majority of our students are still coming from white middle-class backgrounds. And we're trying to recruit, but sometimes that's a challenge to still get people, frankly, because graduate school is expensive. And so if they're particularly first generation, and again, that's not the case across the board, how am I going to pay for graduate school? In our program, you come in, you do an intense 2 years. You aren't paid for the internship hours you put in. In one semester, they have to complete 600 hours, one semester. Many of them are having to work. They're having to work in addition to that 600 hours, and they're taking coursework on top of that. So in some ways, the system is kind of set up, I think, particularly for that first gen population who might be bringing in more diverse students. So for me, one of the ways we're going to solve that is we need to start funding our students and not providing, you know, repayment afterwards. We kind of looked at this last year in one of the projects we're working on. It's great if we provide student loan repayment, but when you don't have a guarantee of a job, and when you start your job and you have 2 years that you're still trying to do supervised experience, a lot of our students are really disappointed right now as they're accepting their first positions and finding out this is not the financial gain they thought they might be receiving. So we also need to work on pay parity to attract more people to the field. All right, soapbox over for 5 minutes. Let me turn that over to somebody else. Thanks, friends.
As you're doing the research, do you also plan on hiring or bringing someone in the team that is also of a diverse background? Because as of now, the research is being done by predominantly white people, and then it loses that racial equity lens because it's not there because you're doing it from a white perspective. I think that's also important when you're doing this research, that there isn't even enough data that truly reflects our experiences.
Yeah, and that is the plan. We need to find people and identify people who can come in and do the research with the right perspective, people of color. And so we haven't gotten to that point yet, but we're working on it. And so we're hoping by this fall even maybe we'll be able to get someone in to start working on that.
I think I'll keep going and I'll pause. Or did you have one more?
Well, there's
Sorry.
quite a few questions.
Oh my, okay.
So,
Go for it. Go for it.
I think before, because there's quite a few questions around wanting to talk about solutions.
Yep,
Like to
which
this
we
problem.
will
So
get there.
before we launch
Yep.
into that, there were a couple questions. One in line with, you know, approaching this from a community perspective. So not just having access to counselors, but also the community being more mindful of this. We actually had a question from a reporter who had a recent suicide in their small community, wondering about what's the best approach in talking about that with the community and reporting on it that's also sensitive and also not making them feel guilty. Like, how do you kind of raise this issue as a reporter when it is occurring in small towns?
I can jump in on that.
You may want to repeat the question just in case, sorry.
So the question was, how do you discuss suicide?
How do you report on it in a small town?
How to report on it in a small town?
Yeah. There are some best practices for how to discuss suicide and mental health. The Minnesota Department of Health has a fantastic handout called Safe Messaging that kind of outlines some of the basic ideas about words and language to avoid, words and language that can build kind of a story or a narrative of hope for those people that may be susceptible to suicidal thinking. So I think for the reporter, I have access to a wealth of resources, and actually I'm working on developing a class for reporters that NAMI Minnesota will be giving to help support that type of messaging and reporting. What's the best way to report honestly about it, to open up the conversation, and still be safe? Because sometimes when reporting is sensationalized or it's reported in a way that may present suicide as that, like, it may have been caused by only one factor instead of there being lots of factors. Like every suicide has many different factors in it, but if it's a simplistic approach, those people who are vulnerable to suicidal thinking may start to feel like they don't have any option if they're encountering that same situation. So there are some best practices. I can't go into them right now because we've got lots of, but I would encourage the reporter to reach out. You can go to the NAMIMN.org and send an email to our helpline. It'll get right to me and I can send all the resources that I have to help that out. Yeah.
I guess another maybe quickie is once somebody raised a question just about the data. So they're seeing an increase in the number of suicides in older adults. How much of that increase do we think can be attributed to doing a better job of identifying these suicides? And how much can be attributed to the increased social isolation of the last several years? Kind of like parceling out that.
Maybe we can ask Monica, I'll repeat the question. The question was, you know, with this increase in the number of deaths in adults, how much of that can we attribute to, is there just better reporting now of that we know more about suicides, or is it really there's just more isolation and more struggles over the last, you know, decade?
Well, it's probably a combination. I'm a counselor, not a data person, so I'll leave the beginning of that question to that. But I know isolation is a very real thing, and especially talking about our older adults. I work primarily with farmers and farm families, egg producers, and the rural population is aging, and many of those folks, especially living rural out of towns, are staying in their homes longer. They are often very isolated during winters for health related issues. The list goes on. And so with that isolation, of course, comes a risk. It's a risk factor for suicide.
Thank you. You know, we've had some questions about, you know, then what do we do about it? All of you have said, you know, we know there's a stigma around suicide, talking about suicide, mental health. Then how does anyone here tuning in today, excuse me, how do we go about changing that? And I'd like to ask all of you that. Where do we start in changing that?
Boy, you know, I'm the policy and the data person, so
Maybe we'll
I've
pass.
actually had that question myself of how do you start the conversation around stigma?
So I think you start it by literally having a conversation. I have this running joke in my household that all I do is talk about suicide. I talk about suicide a lot. So much so we were at my husband's Christmas party and they're like, what are you doing? And so I start talking about suicide at the Christmas party. And about 5 minutes in, I went, oh, maybe I should at least read the room a little bit here, right? And on second thought, I also decided this is actually important, frankly, probably no more important than Christmas time because we often see an increase around the holidays. So we have to start having this conversation as though it's a normal part of our everyday conversation. And Marnie and I talk about this in the report, but I am so excited about this concept. The more we talk about it, the more excited I get, is we have to have anchor members in communities. So here's the reality. As a mental health counselor in a small community where I think I had a lot of trust from clients, from the community, I was never the first phone call. I am never the first phone call when somebody is considering suicide. So we have to start picking up the people who are going to pick up the phone first. And so for us, that could be your local teachers. They're going to catch a lot of our K-12 kids because they're in the space with them. They've developed a trusting relationship. We have to start talking about clergy. And I mean, we're already doing some of this work. I know David can talk about that as well. We're already starting to have these conversations with people. So we talk to clergy because clergy, who do you trust more in your community? You're going to go to a clergy member. You're going to go to a parent sometimes. And so even having parents who have that conversation, rural communities still really function with the patriarchy quite a bit. And I don't say that in a negative way. It's just a reality. There's often a head of a family. One of my favorite conversations with a grandfather who called me after we'd hospitalized his granddaughter for some suicidal ideation. And he told me, he's like, we don't do that. Here we take care of our own. And I think that's a really important thing to understand is that in so many communities, he wasn't being mean. He wanted to take care of his granddaughter. And so it was having conversations, obviously keeping confidentiality in mind. I can't tell you about your specific child without a release, but I can start to talk to you about how do you have a conversation about suicide. I had a farmer I was dealing with who was really worried about his father-in-law. And so we're in our session and I've been working with him and he was telling me about it. And so I finally stopped and I said, do you know how to have a conversation with him about suicide? Is that something you feel okay doing? And he's like, absolutely not. And so I didn't charge him for this, but we spent the next part of the rest session saying, here's how we talk about suicide when we're worried about people. And just starting to do that, starting to tell people how to have conversations about suicide. And I know NAMI Minnesota, I'm like, I know you're probably chomping at the bit now, is doing a great job of doing that in communities. But for me, including more practitioners is amazing if they're the right practitioners, which we talked about in there. But practitioners alone are not going to solve this issue. We have to have people in the community that are trusted members of the community that we have this conversation with. All right, I know you're dying, so go ahead.
In terms of reducing the stigma and the taboo around mental health, it starts with conversations like this. It starts with accepting that mental health is part of people's general well-being. It's part of healthy living. In terms of talking about suicide, we have to acknowledge it is uncomfortable, but it's common. It's part of being human. That potential to have suicidal thoughts is part of being human. And I think accepting that and starting to talk about it that way, as this is just another way that people who are under stress may deal with some of that stress, but it's okay to talk about it. It doesn't mean that they're bad. It doesn't mean that they are committing a crime. And so I talked earlier about some of the language we can change, and it's really common for people to say that somebody who died by suicide committed suicide. Both my parents died from cancer. I don't say they committed cancer when they died. They didn't commit a sin. They didn't commit a crime. It's not a crime to struggle with your mental health. It is not a crime to struggle with the stresses of your daily life. And it's not a crime to have suicidal thoughts. And so I think that just changing that language can start to open the door that maybe it's okay for us to talk about it, for me to admit that I'm struggling. I think that a really powerful part of the report that you wrote was discussing how It can open the door, especially among the rural culture that really values independence and the kind of masculine, I can take care of myself kind of ethos that goes around, to address it as, well, you may not need it, but you can help your neighbor. You can keep an eye out on the other members of your church congregation. And to open the door to that, to address some of the realities of the cultural realities, but get at it. One of the strengths of rural communities is caring for your neighbors, banding together. Use that as a way to open the door. And I could go on, but I know we've got lots of questions.
One thing to mention in the chat, and you don't have to repeat it, apparently they can hear me good. The Minnesota Department of Ag and the Minnesota Department of Health and 2 other organizations just opened registration for a suicide prevention skills for rural clergy today.
Yep.
Oh,
Okay, I was going to talk about that.
Oh, okay, sorry.
So, but I could talk about it right now. Another piece of the report, and you already mentioned it, was the idea that we need to have more, what was the word you used? The anchor members of the community, members of the community that are comfortable talking about suicide, that are comfortable talking about mental health. And an obvious place to start, a trusted member of communities, are clergy. Starting last year, there's a leader in the suicide prevention community in Minnesota named Glenn Bloomstrom. And he is a retired Army chaplain. He is one of the leaders of an organization that has created some of the most widely respected suicide prevention programming. It's called Living Works. And he developed a program called Living Works Faith. And it's for faith leaders. It's an online program to teach faith leaders ways that they can support people that may be having thoughts of suicide, how to identify them and how to best support them. He also has created cohorts of rural faith leaders in Minnesota and the surrounding states. And his first cohort was last year. And I just got the email right before I left and printed it up quick because I wanted to talk about it, but he's opening up more cohorts this year for rural faith leaders in Minnesota, North Dakota, South Dakota, and Wisconsin. And so again, if there are faith leaders on this call, you can reach out to me afterwards, and I can send that information on.
Great. Monica, how would you say, where do we start in trying to break that stigma?
Well, and I think we're making progress by having conversations like this. So I'll echo the answers around having conversations, and it's conversations in real life, everyday situations with people. It's also bringing trainings to local communities. So we are so fortunate to have the Department of Ag and Department of Health have really broken down the silos and worked together to train folks, to bring QPR and Safe Talk into rural communities. I just talked to Northwest Minnesota Foundation, shout out to them. I just contracted with them to do a number of Safe Talks in northwestern Minnesota, and they have their I guess charge to me was to do ag focused and Native American focused Safe Talk trainings. And even yesterday I had a bartender reach out to me, a tavern owner, and tell me that, you know what, I'll give you use of the community room in our tavern at no cost for a Safe Talk training, and I will be there because they hear it, they see it. So it's having those conversations everywhere and anywhere. I've stood in barns, in fields, in cemeteries with people, having conversations around their struggles, their hurt, their risk factors, and then helping them.
Yeah. I want to just jump in real quick to clarify. Monica mentioned Safe Talk. And so there are a number of evidence-based suicide prevention classes. They're called gatekeeper classes that help to teach people how to recognize when somebody might be experiencing a suicidal crisis, and then what to do about it, how to confirm that they might be in a suicidal crisis, and then how to connect that person to help. QPR is one of those. NAMI Minnesota has worked with a number of experts, I think back in 2018, and I think Monica was one of them that helped develop an ag specific QPR class. Safe Talk is that QPR takes about an hour and a half, and it can be done online or it can be done in person. Safe Talk is about a 3 to 4 hour class. It's a little more involved. It was developed by that Living Works or the company that Glenn Bloomquist worked for. So and I know that Monica has also been involved in adapting that content for an ag specific or rural specific audience. And so I just wanted to clarify that when you were talking about Safe Talk, I don't know if everybody in the room or in the audience would know what it is.
Thanks for that, David.
Yeah.
One other thing worth mentioning, somebody on chat said there will be a mental health first aid training in April, done in Spanish in Rochester, Minneapolis, St. Cloud, and Worthington.
Great, thank you.
Details are getting coordinated now. Related to that, people are asking, is there a clearinghouse in which resources are kind of pooled in versus, you know, the research as well as opportunities for trainings and things like that?
NAMI Minnesota has a wealth of resources to share with people. In terms of coordinating training, one of the goals of the 2023 to 2027 Minnesota State Suicide Prevention Plan is to have a more centralized system to where to go to request suicide prevention training. And along with that, also knowing who all in Minnesota is trained to provide them, who is certified to lead all the different trainings. Actually, that is the focus of the NAMI Minnesota grant with the Minnesota Department of Health, is to provide that. And we've hired a new coordinator that is just the Suicide and Mental Health Training Network Coordinator. And she's been on the job for about 4 or 5 months now. So things like that are happening. In terms of information clearinghouses, NAMI Minnesota has information, but there's national websites. SPRC.org, the Suicide Prevention Resource Center, is a great source. The American Foundation for Suicide Prevention is a great resource. So there's a number of organizations that have really high quality information, some of it in multi-languages. And so, you know, I don't know if there's a place where we can post some of that afterwards, but maybe in the comments to the YouTube recording, I can have to leave some links for that type of thing.
For sure. You know, the report, it talked about risk factors. You know, it noted some of the higher risk groups for suicide. Veterans, youth aged 10 to 24, middle-aged men, people with disabilities, Black Americans, LGBTQ plus communities, Native Americans, and then it talked about childhood experiences also being a factor. Can you talk about, when we look at your childhood, how much of a role does that play for someone when we look at the long-term risk for suicide? Maybe I can start with anyone, but Tracie, we can start with you.
So there's definitely a correlation. So, and it depends a little bit on the examples. I mean, obviously in my practice, I deal a lot with cases that are coming forward of child abuse or, you know, and people dealing with those long-term effects. So there's definitely a correlation between the two, but it's not a one-to-one. I mean, so there are people who may have had horrific childhood experiences who may not necessarily become suicidal in the future. And yet I would say it's probably more common than not to have some of those adverse childhood experiences come across when we're dealing with someone who's got some suicidal ideation. But I kind of want to go back to what David said. It really comes down to what's our feelings about helplessness and or hopelessness at this moment. So if we're dealing with feelings of helplessness, we're dealing with feelings of hopelessness, that's really going to increase that suicidal risk behavior. So that probably is a bigger deal, and that could be triggered by other factors. So job security is a big one that could trigger that. Relationship issues. And I know Monica and Ted, who's not with us today, really talked a lot about like that with farm stress, that how much the relationship really plays a role. And I know Monica, who, by the way, is one of the most amazing people I've had the opportunity to talk to. We talked a lot about, you know, farmers. You have the farm widows. So every year during harvest, I would have what I called my little group of farm widows who are doing it on their own, and what that looked like for them, because the relationship is just not able to be the same in those moments. And so relationship factors really can create a lot of that stress as well. But again, if you've got some of those adverse childhood experiences, it increases your risk, but it isn't necessarily directly causational of it.
Got it. The report talked about the 988 number, and you touched on this a little bit in your presentation, but maybe we could start with you, Monica. How is this useful, and why should people know about this 988 number?
Oh gosh, so critical when we are in these rural areas and we don't have 24/7 accessible services that we can just drive ourselves or someone who's struggling to. We need 988 to fill in that gap. So that when I'm doing kind of safety planning or listing resources with clients who are struggling with suicide, 988's at the top of the list every time, followed closely by mobile mental health crisis teams. That's another huge plus we have as Minnesotans, is that we have the mobile mental health crisis teams available. So yes, 988, having just that phone number change and doing the outreach around it, critical to the state.
I want to also jump in and say that the legislation that created the 988 three-digit number also increased funding dramatically for the call centers. And so prior to that, the old 1-800-273-TALK number had 2 crisis call centers in Minnesota, and right now we're at 5. And so along with that increased number of call centers, the wait time has been dramatically reduced. So that if people do call in, they are not waiting. I think that the last quotes were less than 40 seconds before they're connected with a counselor. The counseling training is also been increased, that many of them have gone through the 2-day assist training, which is kind of the gold standard for how to intervene in a suicidal crisis and kind of stabilize that person in a way that can then connect them to more long-term health. And so the effectiveness of 988 from statistics are very impressive. That I think it was about 93% of callers feel like they have de-escalated just on the phone call, and then about 4% I think are maybe referred to mobile crisis teams that Monica mentioned, and then less than 2% are referred on to the EMS services. And so it's a effective tool. It's also can be completely confidential. That I think people worry that if they call 988, then they're just going to send the police out, and there's no geolocation to the phone number. There's no unless the person volunteers where they are, then there's really no way. It can be completely confidential. You don't have to share your name. So.
A great resource.
Yeah, for sure.
Tracie, in the
I got a question.
oh, I'm sorry. Yeah, go
I
ahead.
just wanted to ask the 988 too, that I appreciate that there's a text.
Yep.
That you can text 988, because there's younger people or people who don't want to talk, but they will text.
Yeah.
So people like that, so I always tell people you can call or text, and that gets kind of hooked. Because I don't go ahead and talk, I can text somebody.
Yeah.
So I like that.
Yeah.
feature of it.
Yeah.
We had a comment that you can text as well with the 988 number, which is great, just making it more accessible.
And we also probably should point out, it's not just for suicide.
Right.
There was a time where we thought it was just for suicide, but it's for any mental health crisis as well as substance use issues. So for people who may just be experiencing something they need to chat about, you can reach out for a number of reasons.
Yeah. And I also want to emphasize, and a lot of people don't know this, is that if you're worried about someone else and you don't know what to say, you don't know what to do, you can call the crisis counselor, describe the situation. They could suggest how to do it. They can also, if you ask the question and somebody says that, yeah, they're thinking about suicide and you have no idea what to do, you can call 988, describe the situation, and they can help facilitate the conversation. They do that type of thing all the time. And so it's a great tool.
Looking at the recommendations from the report, can you talk about, Marnie, what are the recommendations? What did we take away from this?
Well, there was the anchor members that we talked about, getting community involved, because these are the people that people in rural communities will turn to first. And then there is the integrated behavioral health, which is where you have having a mental health or behavioral health person at the same clinic where the person may be going for their health care, because they will, this person has maybe been going to the same doctor for years. They may be comfortable talking with the doctor. The doctor may recognize that there's something going on. And so if the doctor can then say, I'm going to bring in this other person to talk to you for a few minutes. The benefits of that is it connects someone to the mental health care provider. It also does it in a private, anonymous way. And so it's just facilitates that meeting. And then there was, what were the other two?
Rural competence.
Yes, rural cultural competence. So making sure that providers are trained in that to understand that rural does have a culture and that it is much more helpful if they understand it. And what was the fourth one?
Blinking on the fourth one.
Yeah.
I'm like, I should know it. I wrote it.
Yeah.
Cheap.
Okay, Chief, I've got a report here. Okay.
Like, I don't know why I can't come up with it.
3. So that was the,
Talk about suicide, is that it?
Maybe normalizing the conversation.
yeah,
I think
It
that
was-
was it, yeah.
I also want to talk a little bit about the concept of talking about mental health, just generally. So one of the things I'm working with a colleague on is we're going to be doing some trainings, and instead of talking about mental health, we are now changing that language to talk about brain-based behavioral health and strategies and interventions. And that seems like a subtle shift, but it's really not. And the reason we say that is, how many times have you heard someone say, oh, they're so mental? I mean, we have used this in such a negative way for so long that we want to shift some of that language to talk about the fact that, frankly, what's happening is brain-based. How anybody familiar with the work of our friend, Dr. Amen, who does the hand-brain model? Hand-brain model is my favorite thing, so I share about this a lot, but it essentially talks about the way our brains process information. So as our brains are processing information, when things first come through, it actually goes through your emotional center before it goes to your thinking brain. And so when I started talking to people about the fact that you don't even have time to think about something before the brain activates your emotional center. So when people are like, why can't I just stop thinking about this? Why can't I stop being depressed? Because that's not the way brains work. They don't function that way. So when I can start talking to people about the fact that this is a brain-based issue, this is the way your brain is functioning, and good news, brains are malleable. We can shift that, we can change it, but we have to acknowledge what it is we need to change before we can make some of those shifts. So I think as we're normalizing conversations, we have to have a really different conversation about, yeah, it's mental health. And I want to continue to talk about mental health, but there's a different piece to this. And I think if we can make it more palatable, particularly in rural populations who still live under this myth of, I should be able to pull myself up by my bootstraps, I should work harder. If I just thought about this differently, why isn't my gratitude journal making me not be depressed? Then we really change the conversation a great deal.
I want to pause and see if anyone did have, I know there's questions coming in right here. Yeah.
Along that line, you touched on it, but talking about this as a brain disease,
Mhm.
I think is not all bad, but we have to be a little careful. We don't want to
Of
make it
course.
sound like you've got a bad brain, but we, back to the cancer analogy, we don't, we talk about colon cancer, breast cancer, whatever it might be. And this is a disease of the brain after all.
Mhm.
So do you think was that helpful?
I think it can be. I think you're right, though. We have to be cautious because people think, well, my brain's broken or it doesn't work. Actually, the brain works exactly the way it's supposed to. Your brain's primary job is to keep you alive. And I tell people, most people's brains are drama queens. Frankly, they are. They see danger around every corner and they respond to it immediately. And that's the brain's job. The brain's job is, let me keep this person alive and breathing. And that's the reason that emotional response will often happen before the thinking response happens. It's because your brain's job is danger, and everything sometimes to brains are danger. So we have to kind of, again, shift that idea. It's not that your brain's actually even broken or wrong. Your brain is just a little dramatic sometimes, and we have to shift it just a little bit to make it most functional for you. I'm not trying to change people's personalities. I'm just trying to make it to where their personality characteristics function the best for them. I've had multiple clients tell me, I don't know who I am apart from my trauma or my suicidal ideation. I have one of my very first clients is like, I don't know if I want to take away the suicidal ideation. I've had it for a long time, but I want to be more functional with it. And so finding a way to kind of normalize even that, which is you may have thoughts. I have people who have chronic thoughts of suicide, and that doesn't make them bad or broken. So helping them understand that piece, I think, is really key. So I really appreciate your comments.
Right here.
I have just a niche question, maybe for Marnie, following up on the firearms research to get
Sure.
back to like policy solutions. Do you have any additional information about why that is? I mean, maybe this is ignorance or bias. I would think that in like more volume of people areas, there would be like more places where you could buy and access firearms. But if there's just more firearms in rural areas, is that because of hunting or because of just, is that some of the rural culture around self-defense? Do you have any just like additional thoughts about that, or what could help with that in terms of?
Yeah, well, I think, and I remember, I think it was Monica that talked about gun culture in the paper, but people in rural areas there is just more, I don't know if you want to call it comfort with guns. They're just used to having them around for things like hunting and protection and collecting and whatnot. And so there is, so that does just make for easier access to guns. Now, one of the things we talked about in the paper was the new, what's called the red flag law, and that was approved by the legislature this last year. And is that a solution? And that's a hard question to answer, because in the law, it talks about how if the person is deemed to be an extreme risk, which is the term that they use, to themselves or to someone else, a person can apply to the court, and the judge would then look at the merit of this application and decide, does this person need to have their guns taken away from them? Well, you can kind of imagine what the fallout of that would be in today's climate. But there are, but between the doing nothing and doing the, red flag extreme risk thing, there are alternatives to that. And one of the things we talked about in the paper, and then we talked about quite a bit on the podcast that is coming out tomorrow, I think, is things like conversations around lethal means, I think is what it's called, or calm. And that is teaching people how to have a conversation with a person they're worried about. So it's like, so it's not like, we need to take your guns away. We need to call the sheriff. And because one of the last things people want in rural communities is to have a sheriff's vehicle sitting in their driveway. You can just imagine what that's going to be like. And so, it's more like, I'm worried about you, and I'm worried that you have the guns in the house here. Let's do so, why don't we take the guns to your brother's house until you're feeling better? Why don't we put the guns in the gun safe, and your wife can change the combination? She won't tell you what it is until you're feeling better, because there is this issue of impulsivity where a person can be thinking about suicide for quite a while, but actually taking the action to do it is an impulsive act, and it can go by, it can pass in like 5 or 10 minutes. But if in that 5 minutes they have a gun at hand, it's too late, and so.
So I can jump in because I teach calm. And that idea of how short a suicidal crisis is really important to understand. That, like you said, people may have thoughts of suicide for days, weeks, months, years. But that time of heightened crisis, when somebody has made the decision that they're going to end their life, and when they actually make the attempt, they've done some reliable research that for about 25% of the people, it's 5 minutes or less. And you get up close to 50%, it's 20 minutes or less. And then it's, I think, close to 90%, it's under an hour. And so that means that when people are in that heightened panic crisis, that they're in that emotion brain, they can't think straight, they can't. And so the idea is if somebody may be having thoughts of suicide, is to try to work with them to come up with a plan to put time and distance between something they might use if that crisis arises. So it's a collaborative process, and it's not a punitive one. It's this is reality, this might happen. And if that's easily accessible in that 5-minute period, that could have tragic outcomes. And so again, that's calm is a very good tool. The ideal is for any type of this type of situation to be voluntary, to be collaborated with, come up with families, the person who may be having thoughts, their healthcare provider, their minister, trusted people, to be able to have that conversation. So there's a couple different versions of this. You mentioned it's conversations about access to lethal means. And that is more the general public. And they are just developing that. The counseling on access to lethal means is a class that's been taught for over 10 years. And that's really more designed for health practitioners, ER docs, mental health providers, social workers, that type of thing. And so, you know, the idea is to just have more of those conversations, and that recognizing that guns aren't bad, that the goal isn't to like take away somebody's gun. It's all about safety, and have those, how can you stay safe while thoughts of suicide may be strongest? And that's the main focus. And I think it's really important to understand that. In terms of the red flag law, or the term, it's the extreme risk protection orders. And there were a couple things when I read the report, it described how one piece of it is that a mental health provider would have to report. And that's not part of the law, that was removed from the language. I confirmed that with our advocacy arm before I came.
That was in the legislation that I read.
Right.
Okay.
And so that is not part of the law that passed. Mental health providers do have a statutory obligation to report, but that's kind of a separate law. And so this doesn't apply, the red flag law doesn't apply at all to mental health providers. What it does apply to is if a family member has a concern, or a friend, somebody close has a concern that somebody is at risk to themselves or to others, that they can file it. It can be filed electronically, it can be filed in person at a court. And then the judge will determine, is there a reason to do that? There's two different kinds. There's an emergency protection order where the judge will determine that this is imminent and it needs to be taking place now. And then that can only, I think, be in place for 21 days if there's an emergency order. And then if there's a more long-term order, then it has to be a whole hearing where the person that may, be at risk would have a chance to talk with the judge, and there'd be a whole hearing. So it is not something that comes from a mental health provider. I don't want people to think that if they reveal to a mental health provider what their thoughts are, then that would automatically have a sheriff at their door, because that won't happen, under this law.
Thank you. I want to be cognizant of time, so I want to ask all of our panelists a final question, and that is, for people tuning in today, if they could take your big, one message away, and I know there's so many, but if you each had to pick, I hope you take this message away from this discussion today, whether it's something in the data or exploring solutions going forward, what would you want them to take out of this conversation? Marnie?
I think the importance of the idea of informal mental health care combined with formal mental health care, that idea of anchor members of the community. And just anybody having the capacity to help someone. And, that we can all be a solution.
I probably am going to echo a lot of that sentiment. So the word I keep using is the acceptability piece of it. So when we look at rural communities, we have issues with accessibility, availability, and acceptability. So when we start to use those informal resources, we start to increase the acceptability of talking about these things in rural areas. And I will follow that up by saying, contact NAMI Minnesota and do some training. I think that really might be one of your best bets.
For me, I think that just along those themes is it's okay to talk about it. That it's important to talk about it. And one way you can do that is by training. NAMI Minnesota offers a free rural QPR class every third Tuesday of the month, taught by Emily Kreckelberg. And we can also, if you reach out to us, we can put on one. I did one last night that was with the Swift County Public Health Department. That was online, but there was also a room full of 30 people in Chicago that were part of that training. And so you can reach out to us, and that's our mission, is to do this. And we encourage you to reach out to us.
Monica.
I guess I would just say, notice the people around you. We get so into our busyness and our tasks and what we need to focus on. And a lot of people are hurting right now. And any of us can notice the people around us and notice if they're hurting and be there with an invitation to talk and listen. So I guess that would be my closing thought.
Thank you so much. And with that, I definitely want to thank our panelists. Thanks to Citizens League and the Center for Rural Policy and Development. I'm sure there are even more questions that we did not get to. And that just means there's so much interest in this topic and so many people who want to help. So thank you, especially to everyone who attended today, whether in person or online. Just to note again that this recording will go up on YouTube. So feel free to share this with people who will also be interested, or to keep continuing that conversation like we've talked about, and follow these organizations on social media, Facebook, Instagram, Twitter, and keep an eye out for more research from CRPD. Everything is posted on their website. And thank you so much for joining us today. Have a good day.